Hello. Hello, everyone. I think we'll be just starting on time for the session. My name is Majid Alkharashi. I'm a cornea surgeon here in Abu Dhabi. It's a pleasure to welcome you again here in Adore 2023. We'll have a session about fighting corneal blindness. I have a panelist with me, Dr. Mohammed Al-Mutlaq, who's a cornea consultant at KKish and the chair of the Eye Bank in Riyadh. I have also Ismail Arbabi, another corneal consultant friend from Moorfields, Abu Dhabi. He brings also a wide experience from UK and previously a staff at the University of Liverpool. And the third panelist is our guest speaker from the USA, Dr. Sadir Hanoush. Dr. Sadir Hanoush is a world-renowned cornea surgeon, well known for advancing corneal lamellar keratoplasty and artificial corneas. The first talk today is by Dr. Majid Alkharashi, who will be talking about the evolution of corneal transplant. We'll start the session on time. Majid, the podium is yours.
Thank you, Murad. Well, I will not give you a harsh presentation where I will present a lot of numbers, a lot of studies. It will be rather of a story. So I will be telling you the story of evolution of corneal transplant and how corneal transplant got evolved over the years. So please bring along your coffee. If you have popcorn, share it with the guy next to you and enjoy it. Okay, so the word graft derived from the Greek word graphein, which means writing an implement. And they used it to describe their monsters like Chamai here, who has a body of a lion, a tail of a dragon, and an extra head. It was used in the 15th century by agriculture, where they will take a branch of a fruit tree and graft it into another fruit tree. However, it was not used in medicine till the late 19th century. Corneal scar because of trachoma was really a problem in the 18th century in the French and British soldiers who were campaigning in Egypt during the Napoleonic War. And trachoma was the reason for the establishment of ophthalmology as a first surgical subspecialty. And it gave the stimulus for the foundation of Moorfields Eye Hospital back in 1817. You know, as anything new, it usually starts with thoughts and idea. And Quincy in France thought of replacing an opaque cornea with a transparent material. And actually, this is his drawing where he did the steps of the surgery, the instrument that will be used to replace cornea. And the first one who did the experiment was Hemley and his student Risinger in Germany, where they took a cornea from an animal and transplanted it into another animal. At that time, there was a debate of either using a xenograft or doing a xenograft or allograft. Xenograft is where you will take the cornea from an animal. Allograft where you will take it from the same species. And Richard Cassim in 1838 did the first xenograft where he took a cornea from an animal and placed it into a patient that failed within 10 days. And von Hebel had a lot of contributions in ophthalmology, one of which he developed the circular corneal trephine to cut a circular cut in the cornea. Von Hebel was in favor of doing a xenotransplant. However, he suggested not to do a full thickness corneal transplant, rather to do lamellar keratoplasty, as he thought that the corneal endothelium play a major role in keeping the cornea clear. The first one who did a successful allograft in a human is Edward Zerm in 1905. He is an Austrian ophthalmic surgeon practicing in a city near Prague in the Czech Republic, where he encountered a patient by the name of Gloger who had bilateral chemical injury 2 years prior to his presentation to Zerm. In the same day, Zerm had a child actually with a penetrating trauma that needed inoculation. So after taking permission from the child's father, he cut the cornea into two 5 millimeter corneal button, and he did a bilateral corneal transplant to Gloger. The right eye failed immediately, and the left eye stayed clear, and Gloger was able to go back to his daily activity. Corneal transplant was like 50 years ahead of other organ transplant. Like it preceded kidney transplant by 50 years. And one of the reasons for the successful outcome in corneal transplant that the cornea is avascular tissue, and there was a lot of advancement in ophthalmology since that time, one of which having like fine, tiny suture that will allow you to suture delicate tissue, microscope that will improve the visualization, having anesthesia, and Lister described aseptic technique in surgery that decreased the postoperative infection. Vladimir Flatov in Russia came up with the idea of using cadaver cornea, where you will take the cornea from a dead person rather than a living person. And Richard Patton in New York established the first eye bag in 1944. Edward Momini discovered that one of the reasons for corneal transplant failure that the immune system will attack the endothelium and will cause rejection. The topic of lamellar keratoplasty been revisited again, and this is because of the advancement in the diagnostic tool as well as the surgical instrument. And as you all know, there are, and as you will hear, there are many advantages of doing anterior lamellar keratoplasty instead of full thickness keratoplasty. For me, at least, endothelial keratoplasty is more interesting, and Tylett in 1955 did or described the technique of posterior lamellar keratoplasty, where you will do a large limbal incision, then you will dissect the posterior lamella of the cornea, then you will take another posterior lamella and you will suture it in place. However, the surgery was very difficult, a lot of complications, rejection, sutures, etc. Dr. Millis had a major role in the development of endothelial keratoplasty. First, he came up with the idea of using air tamponade instead of suturing the posterior lamella, then doing a dysmatorexis, and finally doing a DMAC. This is a patient who had DSEC for pseudophakic bullous keratopathy 6 weeks ago, and she's seeing 20/30. She's extremely happy, and I am extremely happy. And we thought that we can't really beat this till we start doing DMAC, and this is a DMAC 1 month after the procedure. If you look at the literature, there are many advantages or some advantages of doing a DMAC over DSAC, better vision or better visual quality, less risk of rejection. However, if you look at this Cochrane review, they found that there is low certainty evidence that DMAC provide better best-corrected vision over DSEC at the cost of more complications and rebubbling. So you have really to choose your battle. In our region, we see a lot of patients with corneal scar because of trachoma, abnormal anterior chamber. So usually we should do what's best for the patient, not let your ego take the control. So sometimes doing a DSEC in a patient with a corneal scar post-trachoma could be a reasonable approach, because this patient anyway will not see 20/20 because of his trauma corneal scar. Thank you.
Thank you, Majid. Excellent talk, excellent introduction for this session.